Welcome to Triage Cancer's webinar, Understanding Hospice. My name is Madison McMahon Ward, and I am the Program Coordinator for Triage Cancer. I will be moderating today's webinar. Now, before we dive into today's topic, I just need to go over some housekeeping. All callers will be muted for the duration of the webinar. If you have any questions or technical problems, please type them in the chat box to the side of your screen. This webinar is being recorded and will be available for viewing by the end of the week on our website, triagecancer.org. After today's session, you will receive an email with a link to an evaluation. We would appreciate it if you could take a few moments to provide your feedback. We are very grateful to Novartis Pharmaceuticals and Takeda Oncology for sponsoring the 2019 Triage Cancer webinar series. As part of the accreditation process for healthcare professionals, we have to read the following disclaimers and disclosures to you. This presentation is intended to provide general information on the topics presented. It is provided with the understanding that the author is not engaged in rendering any legal, medical, or professional services. The planners and presenters of this program have not disclosed any pertinent financial relationships or conflicts of interest. While this educational program has received commercial support from the previously listed sponsors, the content of the program has no relation to the commercial interests of the organization's products or services. I am pleased to let you know that Triage Cancer is an accredited provider of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. Triage Cancer is also approved to offer social work continuing education by the Association of Social Work Boards approved continuing education program. Therefore, nurses and social workers participating in the live webinar and meeting the following requirements may be eligible for one continuing education credit. In order to receive contact hours, you must have registered online for today's session. People who are listening in on someone else's computer are not eligible for credit. You also must attend the entire webinar. No partial credit will be awarded. Anyone watching a recording of this webinar will also not be eligible for credit. Within 1 week of this webinar, complete an evaluation and post-test. You must receive a passing grade on the post-test to be eligible for contact hours. You will receive an email following this webinar, which will contain a link to the evaluation and post-test. Please note on the evaluation, it asks for your name and email address. You must include these so that we can certify that you completed the evaluation. That email is the address we will use to mail the certificates. We will be sending out certificates within 4 weeks. For other types of healthcare professionals, we are more than happy to provide a general certificate of attendance. Just make sure to indicate that request on your evaluation. If you have any questions or experience any problems, email us at info@triagecancer.org. In order to receive continuing education credit for today, we have to be able to verify your participation. Therefore, if you are calling in from a phone, you must also log in from a computer or use the smartphone GoToWebinar app and input your audio PIN. You can find the audio PIN in the control panel to the side of your screen under the Audio tab. If you are already on a phone, simply press the pound key, the number you see on your panel, and then the pound key again. For those of you who aren't aware, Triage Cancer is a national nonprofit organization that provides education on the legal and practical issues that impact individuals diagnosed with cancer and their caregivers. And we provide this education in a few different ways. First, we host a Speakers Bureau of experts in all types of cancer survivorship issues available to organizations putting on an educational event. You can read our speakers' bios and request a speaker on our website. We also participate in events all over the country. Some of these events are hosted by our partners in the cancer community, and some are events we host ourselves. To see where we are going to be, take a look at our events calendar. For every year, we host 3 Triage Cancer conferences. This day-long event covers a variety of cancer survivorship topics. We welcome patients, survivors, caregivers, advocates, and healthcare professionals at this free event. For the remainder of this year, we will be in Chapel Hill, North Carolina, and Houston, Texas. Registration is still open. We provide free CEs for nurses and social workers and CLEs for lawyers. As you know, we host monthly webinar series open to anyone in the cancer community. The next one is on October 16th, Avoiding Financial Toxicity. We are delighted to announce that we will be providing free CEs for nurses and social workers for the remainder of our webinars. Recordings of past webinars are also available on our website. We also host 2 educational programs that are specific to healthcare providers. The first is the in-service for healthcare professionals navigating cancer, work, and insurance. This program is delivered in partnership with Cancer and Careers. The second training for healthcare professionals is the Insurance and Finance Intensive. This is a comprehensive certificate program for oncology healthcare professionals and advocates on health and disability insurance and finances. You can get more information and register for any one of these programs on our website under the Events tab. In addition to our events, we offer a number of educational materials and resources online. Our quick guides are designed to be a snapshot of a particular topic. They cover areas such as health insurance, employment, clinical trials, financial topics, estate planning, and legal assistance. We also have checklists and other documents designed to help with the legal and practical pieces of cancer survivorship. All of these documents can be downloaded for free on our website, or you may order hard copies of the materials on our website at triagecancer.org/material request. Because we recognize everyone learns in different ways, we also provide educational animated videos on cancer survivorship topics. We recently released 2 new videos, one on clinical trials and one on cancer survivorship care plans. We also have videos on health insurance and employment topics. These videos are available in English and Spanish, and stay tuned as we have more videos coming soon. We are also very excited to announce that thanks to the support of the California Dialogue on Cancer and Genentech, we now have several resources available in Spanish, including most of our quick guides and all of our animated videos. Again, these quick guides can be downloaded for free on our website. We realize that it can be challenging to find what you are looking for on the internet, so we compiled the contact information for some of the most frequently used state-specific agencies and resources on our site. And because where you live can impact what protections you have access to, we have charts of state laws on employment, disability, health insurance, and other cancer-related issues. Cancerfinances.org is a site that we host in partnership with the SAM Fund that provides practical information on topics that can impact your finances. This website is designed to guide users to the information that is most relevant to their situation. We currently have modules on health insurance, disability insurance, education rights, estate planning, life insurance, and financial assistance resources. More topics will be added soon. And finally, our educational blog not only provides great information about cancer survivorship topics, but because things are constantly changing in the cancer community, this is how we share late-breaking news. And we have our monthly e-newsletter, which is where we announce all of our upcoming events. With no further ado, let me introduce today's speaker, Shirley Otis-Green. Shirley's career is dedicated to enhancing excellence in the delivery of contextualized care to address the symptoms and stress of serious illness. Her education, research, and consultation efforts have led her to become an internationally recognized speaker on quality of life, palliative care, leadership development, and the creation of meaningful organizational change. As principal investigator on studies with over 3.5 million in external funding, her work has been recognized with numerous awards and disseminated through more than 100 publications and 500 professional presentations. She is a California Healthcare Foundation Leadership Fellow, serves on several editorial and professional boards, and is a distinguished social work practitioner in the National Academies of Practice. Shirley was among the first to receive an international interprofessional Master's of Arts in Health Research Palliative Care from Lancaster University in Great Britain and is co-editor of the Oxford textbook of Palliative Social Work. Remember, if you have any questions, type them in the question box to the side of your screen and Shirley will answer them towards the end of the presentation. So with that, I'd like to turn it over to Shirley.
Thanks so very much. It's such a pleasure to have an opportunity to share with you some thoughts in regard to hospice and palliative care. Again, welcome to the seminar and thank you so very much for your interest in improving care for either yourself, for those you love, or for the patients that you might serve. And Madison, I'm not able to move the slide. Thank you. Our objectives for our time today are to articulate the distinctions between hospice and palliative care and how they intersect, and to make sure that we can delineate how hospice and palliative care services are designed to improve the quality of life for both the patients and families. Now, life offers us no guarantees. It's a dangerous enterprise. All kinds of things can happen. I live here in Southern California, so earthquakes are something that we're conscious of. And every day we listen to the radio to hear about accidents on the freeway that might stop our daily commute. So we all need to increase our tolerance of ambiguity. We know that life is really what happens while we're busy making other plans. But a diagnosis of serious illness can change everything. Suddenly, it can seem as if there's an invitation to consider the possibility of our own mortality. And it can feel like a personal earthquake, reminding us that we're not in control and the world isn't as predictable as we might have previously believed. This picture is literally taken on the interstate near our home for the 1994 Northridge earthquake. And that reminder of how suddenly everything was different, I think can be a metaphor for the cancer experience. Now, living with a serious illness takes great courage. Coping with this invites us again to live our lives as if they matter. We're invited to face our fears, and those fears can be tremendous. We can face the fear of distance or disability, disfigurement, dependence, and perhaps even fear of death itself. But there are many potential challenges, but just as many rewards. We know that there can be challenges in terms of physical and psychological, social, spiritual, existential, it just every aspect of our quality of life can be impacted from cancer. But again, we also know that we can have increased intimacy. There can be satisfaction in caring for someone that we love. There can be an opportunity to grow existentially, to reflect on what really matters most. And there can be great satisfaction in addressing and confronting our mortality. We can build a legacy that we're proud of. We can be role models for those that we love. And we can have this time of personal growth. And this can be very meaningful, both for, again, the patient, the family, and those of us who care for those folks. Cancer, again, is a reminder to live life as if it really matters. And it's an invitation again for us to be maintaining a perspective of paying attention to priorities, to pay attention to what matters the very most at this moment for this particular person, for us to be conscious of that. And for most people, what they will tell us is that relationships are what matter most, that we want to be thoughtful about how our daily lives impact those that we care for and those that we love. So our goal, no matter where we are in the cancer trajectory, is to live well, to live authentically, to be able to minimize the symptom impact so that we can maximize the opportunities to do the things that matter most. And we want to minimize regret. We need to be consciously addressing priorities so that we don't look back on any given day and say, I wish I would have known, I wish I would have done, I wish I would have had that experience. We want to make sure that people have what we call anticipatory guidance, that we as providers are helping people to see what might be coming around the bend that they've not yet experienced, but in our position as a provider that we might know is likely to occur. We want to make sure that people have the opportunity, again, to minimize regret by living fully their life experience. Now, unfortunately, patients are commonly going to encounter lots of challenges. There are expert reports that highlight the continuing deficits in the delivery of care, and those deficits get worse at end of life. We know that patients commonly will encounter multiple transitions, preventable hospitalizations, fragmented care, high in-home caregiving needs, high financial strain for the family, lots of opportunities for emotional distress, and too often misaligned treatments. Too often people get the care as if they were on an assembly line. We treat the liver in 206 instead of treating the person around that liver. We need to be much more conscious of trying to personalize our care so that each individual can get the care that best meets their needs. Now, the contemporary, or what I might call here the current and common care model, is that a person is diagnosed with a serious illness, they get a ton of disease-modifying treatments, and then at the end of their life, again, a few people are going to get hospice, but not all. And the people who then come to their cancer are, if they are in hospice, are likely to get some measure of bereavement care. But unfortunately, those that might die outside of hospice are unlikely to benefit from that bereavement support. So although this care model is quite common, we know that there are some real challenges with it. It doesn't address the needs of most people. Our goal is to support patients and families so that they can plan for and reliably receive competent, compassionate, contextualized, culturally congruent, person-centered, and family-focused quality care. Can you tell C is my favorite letter of the alphabet? I think, though, that those words are very uh, intentional in capturing what we might think of as quality care. We would assume that all care is going to be delivered in that way. But when we or a loved one experience cancer, we might be disheartened to find that that's not the case. That again, the normal care delivery system has too many gaps, and we're unlikely to get that level of care. I want to give us a few moments to think historically. The word hospice is actually derived from the Latin word, which I cannot, I'm sure not pronounce correctly, but hostidium, which means hospitality and is the root for the words of hospital and hotel and hostel. It's also interesting to think about the word palliative. That might not be a common word in our normal vocabulary now, but that too comes from the Latin. And that was, again, a word that was meant uh, to be used to cloak or to protect someone dealing with adverse events. So I wanted us to think a little bit about these two words. If we think about quality healthcare, and we think about quality palliative care and quality hospice, we might see then that hospice is a subset of palliative care, and palliative care is a subset of quality health care. But again, from my perspective, it's important for us to be able to distinguish these terms. So we're going to spend a few moments thinking about these just a little bit more. If you think about palliative care, and again, remember, hospice is a part of that, we might say that patients and families getting palliative care are then able to get the information that they need so that they can understand their situation and that their values and goals can be elicited over time, that they will understand the benefits and burdens of treatment and be able to make reassessments about whether to continue or to change their course so that their decision-making process is fluid and again individualized to that particular person's evolving condition. So our goal in palliative care is to be able to have this occur simultaneously from the moment of a diagnosis of a serious illness. While the person is still getting their disease modifying treatments, they would also get the benefits of palliative care. So the person receiving palliative care would be, again, having this ebb and flow as their symptom needs were to increase. And again, all folks who are eventually facing end of life would be able to be referred in a timely manner to hospice and receive the full measure of hospice benefit, which again, in the United States is for 6 months prior to the time of that person's expected demise, and can be extended if it turns out that our guess on prognosis is off, so that the person would be able to receive a full plethora of resources and services so that when that death arrives, their family can benefit from again, extended bereavement care. So the goal would be that all folks would have a palliative care. All folks who are facing end of life would be able to benefit from the advantages of the gold standard hospice programs, and all families would be able to benefit from bereavement care. Now that's a great plan and is recognized and encouraged by the World Health Organization. And I seem to not, oh, there we go. Um, could you move me back, Madison? Sorry. Back one more. Can we go back one more slide? Maybe not. Oh, there we go. I wanted to literally, again, go back in time and to remind us, whoops, we can go back to the one with the skull. To remind us that when we think about healthcare, palliative care can seem like it's a new thing. Many of us are not familiar with the term, and it can seem like it's a new invention. But if we think again from an anthropological point of view, we can see that palliative care was really our only means of medical treatment for most of the period of time that we've had humans. We had very little things that we could actually cure. So being able to alleviate pain and suffering was the best thing that people could do. So having a shaman or a wise person of some sort in a early village that we might have had would be the very best that we could offer, would be to console the family and to offer support to ease the suffering of the person who either would get better or not, but it wouldn't have been necessarily because of the interventions of the healer. So palliative care is actually our standard go-to of how human life existed. And I love this story that was in this picture here from the cover of The Scientist. And it was again reminding us that from our earliest anthropological findings of early humans, we've had burial practices and evidence of clearly taking care of people who were very seriously ill, people that had been injured or hurt, but didn't die immediately from that event. And again, clear signs that the cultural groups around that person were taking care and trying to protect that person over time. So palliative care, again, was our earliest foundation. But then more recently, we began to have antibiotics, and we were able to do surgeries and anesthesia. And oh my goodness, there was this plethora of suddenly we could cure illnesses. And it's as if we threw the baby out with the bathwater and we completely forgot about palliative care and the importance of that. And so palliative care kind of reemerges in the 1960s and 70s as a reminder to us that we still need to think about quality of life. We still need to think about caring for the family. We still need to think about putting this person's need individually and contextually and culturally congruent care. That we need to think about how do we personalize through a holistic and interdisciplinary approach. And one of these pioneers that reminded us of that is this lovely lady, Dame Cicely Saunders, who's credited with, again, the establishment of what becomes the modern hospice and palliative care movement. So we are so fortunate, again, to remind ourselves that now we stand on the wonderful threshold of being able to use the science that we've recently been able to create and the medical advances that comes through with that, and combine that with science and compassion so that we can do not only the physical manifestations of disease, but still attend to the emotional and spiritual and social consequences as well. What a wonderful time. How fortunate we are to not have an either or, but to be able to have both. Now, despite saying how fortunate we are, however, we need to be mindful that there are regulatory and sometimes payment or insurance restrictions that can limit access to these services. Our hope is that in the future, that new payment and service provision models, you might hear of things called value-based care or community-based palliative care or accountable care organizations, that we're going to be able to further refine the opportunities for people to be able to access quality care in a way that's going to better meet those individual needs, so that in the future we'll have less gaps in service and a better and more reliable, more robust system of providing care that truly meets an individual and family's needs. So hopefully I've convinced you that palliative care is the best thing since sliced bread. So how come it's so rare? How is it that so many people are even completely unaware that it's an opportunity or an offering for them? And so we want to spend a few moments in thinking about that. Our healthcare providers, remember, probably got their training before palliative care was even a common option. So many of the doctors and nurses and social workers and chaplains that you might encounter in your daily work in a hospital, or if you're getting treatments, the people that are providing your service, many of those people were trained prior to palliative care being a commonly available service. So their training, their induction into their discipline may not have included palliative care services. So unfortunately, many of the myths or misconceptions that the lay public might have are too commonly also found among healthcare providers. We might hear phrases when palliative care is encouraged or recommended that even the provider will say, oh, nope, that patient or that family, they're not ready yet for that service. And what we hear when we know about palliative care is that really probably means that it's the provider who's not prepared, not the family or patient. We also might have competing priorities. Again, we might be so focused in the few minutes of time that we have with our patients or families that we focus on the symptoms and the medications and the next interventions and forget about paying attention to those other aspects of care. And too often, it's literally not in our job description. Social workers and chaplains and nurses and some of the other care providers that we might see, again, might not have the expectation in their daily job to be paying attention to those other quality of life indicators. It can seem like it's someone else's responsibility. It's something for the specialist palliative care service. We might want to take a moment now to think about palliative care and the principles of palliative care. We're going to talk quite a bit about that in the next few minutes, but about being able to think about those principles as being ideally embedded and integrated into what we could call primary palliative care, that the services that our oncologists are providing, but including those principles and thinking of it as primary palliative care principles. Now, there's also specialist palliative care. And that's where, again, we see people who've dedicated their careers. They might be board certified. They might have done extra training and education so that they can provide absolutely the most, be able to attend to the most complex care needs of people that have really specialized palliative care interventions that are needed. And so too often, again, we can forget that we all have a responsibility, though, to pay attention to the primary palliative care goals. It can sometimes seem as if we don't have the time, or again, we might do a generalization and think in terms of, well, those patients don't want us to discuss these issues. Again, whatever those patients might be. Sometimes if providers are honest, they will acknowledge that they don't want to open up what can seem like a quote can of worms that they're not well prepared and have the time to tackle. And again, we may lack a clear process for how we would do palliative care referrals. So too often, it can seem as if it's too early until it's literally too late, and the person or family doesn't have the opportunity to get the full benefit of the palliative care expertise, nor might they get the referral to hospice or the benefits of bereavement support. So we can have this tremendous challenge that is only escalated when a person is considering hospice. Again, there are the same myths and misperceptions about hospice. There can be distrust of the medical system. It can feel like people worry that it's going to offer them lower quality of care, or it might mean that they get more restrictions. It's often defined of what it's not instead of what it offers. It can even seem as if it's giving up. People will use that phrase. We'll hear that so often. Well, mom was a fighter. She doesn't want to give up. We don't want to give up on her. But hospice or palliative care is not about giving up. It's about paying attention, again, to the quality of life of that person. And we know that for many people, they actually do better and live longer when they're receiving these benefits. There can be concern about healthcare costs or insurance limitations. There can be lack of a care partner or a stable environment for care. And again, there can be that worry that if I have to, quote, give up or stop curative treatments, even if I'm in a situation where cure is not possible, people still like the feeling of being able to choose to have something, and to have to sign off and say I'm not going to have something can feel like it's an artificial barrier, again, to receiving hospice care. And the way hospice is defined in the U.S. with the hospice Medicare benefit, there is an informed consent process where you literally are changing basically your insurance benefit to be able to acknowledge this 6-month or less prognosis. And that can be very disheartening for families and, again, worrisome for patients. So unfortunately, the regulatory requirements that we've here in the U.S. have put around the benefit of hospice can be a barrier in and of itself. So many of the people who would benefit from hospice, again, have it delayed or perhaps not offered at all. So let's think again about what quality care would look like. If we were going to build quality healthcare system, these key principles from palliative care would be integrated from the very beginning of, again, a person's serious illness diagnosis. We would have that interprofessional collaborative team approach. We would want to address the multidimensional aspects of suffering. We would know that suffering isn't just physical, that we need to pay attention to improved functioning and quality of life in emotional, social, psychological, spiritual, sexual, existential, financial, all of those aspects, paying attention to all of that. It would be appropriate for all ages and all stages of the serious illness. Our interventions would be recognized as being relational and communication centric. Things like family meetings are the main intervention of palliative care. We would have collaboration across institutions and professional boundaries with the goal of meeting the patient's needs. There wouldn't be gaps in services. We would be able to offer bereavement support for patients and families and staff members. You might think it odd to say patients, but we know that there's anticipatory loss that that person might have as they're going through their end-of-life experience, and that they're having grief associated with that. And for families, of course, it makes sense that they're going to have extended bereavement and grief. But we also want to attend to the needs of the staff members who are dealing with seriously ill people as well. They too have grief and bereavement and need to have support. So there's a new model. We call it the bow tie model. And it's when palliative care is enhanced, whether the person has survivorship or, again, an end-of-life experience. That palliative care is infused throughout, again, varying as that individual's needs might be, with a focus on ensuring that everyone has really excellent pain and symptom management so that we can have anticipatory guidance, again, minimize regret, and ensure that everyone has the best possible quality of life and the best possible functioning. So, in my humble opinion, palliative care is the answer to most of the problems of healthcare. It enhances quality of life, improves function, and contextualizes care, addressing those multidimensional aspects of suffering through a collaborative team approach to address whatever concerns might arise for that individual patient and family over time. It's really an amazing thing. It can be defined as an extra layer of support. You're seeing your physician, you're seeing your healthcare providers, and you also have the opportunity to benefit from this amazing team of folks who, again, remember C's, my favorite letter of the alphabet. They're collaborating, coordinating, communicating. They're compassionately delivering competent, evidence-informed care across care settings. They're doing courageous questioning. They're asking the tough questions so that we can make sure that we minimize regret. They have a conviction of their principles and a commitment to excellence. Now, palliative care is codified through some guidelines. The National Consensus Project was begun in 2004, has been just recently updated in 2018. We have the fourth edition, and they have maintained these 8 domains. And we're going to talk about each of those in some depth as we go forward. But it's important for us to remember that these are endorsed and evidence-informed. Experts have come together to ensure that we can say what palliative care needs to provide. Under the structure of care, we know that we need to have this comprehensive interdisciplinary assessment so that we can address and create care plans that attend to the values and goals and needs of this individual person. We want to recognize the emotional impact on the team that's providing care and have structures in place so that we can reliably deliver care of that level of quality. We want to recognize the physical aspects of care are so important. If a person's having physical pain or other symptoms and side effects, how can they possibly do the things that matter most in regard to their quality of life? So we want to be able to, again, address distress and suffering across all of these variables and make referrals as appropriate. We know that if a person has serious concerns physically, they're likely to have a psychological component, right? A person might be anxious or depressed because of feeling so consumed by the pain or symptoms of a serious illness. So we want to be able to tailor and target our communication and our interventions to address whatever that person's cognitive capacity might be and wherever they might be along their developmental stage. Again, offering and attending to grief and bereavement concerns for the people that we see. We need to address the social aspects to know that this isn't, again, just the liver in 208, but the patient and the family who have concerns. The roles might change. There might be aspects of school or work or sexuality that change because of the illness, and we want to be able to make sure that we address those and respond to those and have a care plan that attends to those as effectively as possible. We need to make sure that we're mindful that this is not just, again, a physiological experience, but a spiritual and existential one. We need to recognize that spiritual concerns are addressed with the same level of commitment and that we attend to the diversity of people's experiences and beliefs and rituals, and that, again, care is tailored to that individual. We know that there are cultural differences. We want to be thoughtful that not every person has the same comfort with disclosure or truth-telling or decision-making, and that we need to offer a range of services to accommodate different languages and dietary and ritual experiences so that, again, care can be personalized. And we need to be mindful that when people are facing end of life, when we are literally getting close to death, that we are upping our game accordingly. People don't get a do-over at this time. We want to minimize regret, so we have to be very intentional by offering anticipatory guidance, helping make sure that things are culturally and developmentally and age appropriate, that we are, again, as honest as we can be, and yet as attentive and respectful as we and beliefs are. We want to make sure that we do all of this in the most ethically and, of course, legal way possible. That we attend to state and federal law, and that we, again, are attentive to advanced care planning and the special needs of those that might have limited decision-making capacity and addressing the needs of surrogate decision makers. That was a lot. Palliative care is active, intentional interventions that can make a tremendous difference in quality of life. It also, again, reminds us to honor what we might think of as ancient wisdom. Your moms have all probably said, we want to hope for the best, but prepare for the worst. We want to take care of estate planning and wills and guardianship so that we can minimize regret. And we want to make sure to address durable powers of attorney for healthcare, or what we might think of as advanced care planning. So advanced care planning is that process of communication between the patient and family and their team of clinicians so that we can foster an understanding about that particular person's treatment preferences in relationship to that particular illness and prognostic situation. So if that person is having a serious illness, what would we want for that person's goals to be? And to have those again be modified over time as the illness might advance. There have been tremendous amounts of research in this area, and all of our studies indicate that the majority of people would want a death much like this depicted by this beautiful painting of Washington on his deathbed, where here's this great man comfortably lying in his own bed, in his own home, surrounded by the people that love and admire him, who are attending to his every physical need, and he's as comfortable, he at least appears to be as comfortable as possible, again, surrounded by the people that he loves. He's in an environment that he's chosen, in a situation that he's chosen, with the people that he's chosen around him. But if we don't do advanced care planning, if we don't make our wishes and needs known, it's too likely that we'll end up on an assembly line. This is how we treat cancer. This is how we treat people who are seriously ill. This is how we treat people who have a life-limiting condition. And that conveyor belt of services can end us up receiving care at end of life that looks more like this. This picture depicts a person in ICU getting a tremendous amount of physical interventions, but who is unable to recognize or communicate with those he loves, is surrounded by people who, from that person's perspective, can appear to be strangers in an environment that might not be the most restful and conducive to reflective, spiritual, and existential thoughts at end of life. And with the family in this situation, too often inconvenienced and spending time either in the driveway, in the parking lots, on the highway, behind the windshield, spending time getting to and from the hospital, being in the waiting room, again, in environments that's not necessarily conducive for them to receive the kind of solace that they need as well. So we need to be able, through an advanced care planning process, to reflect on our values and beliefs and preferences about what gives our life meaning, to determine who we would want to trust to speak for us if we couldn't make our own health decisions, to be able then to talk with this spokesperson about our decisions, to consider recording our thoughts and are sharing those thoughts with all the people that would be impacted by those decisions so that we can minimize family conflict and prevent future misunderstandings. And ideally then completing what we call an advance directive. Writing that down, writing those thoughts down, our wishes down, our preferences down, and distributing copies by to all of the people who might be impacted by our decisions. We would discuss those preferences with our healthcare team, and we would regularly review and update our advance directive. Now, advanced care planning is a process, not an event. Ideally, it begins when we are 18, where we identify someone to speak on our behalf if something were to happen to us and we wouldn't be able to voice our concerns. We would revisit this as life continues, when we're married, when our children grow up, if we become divorced, when we're diagnosed with a serious illness, if that illness becomes more advanced. And these pictures are such samples of some of the type of tools that are available to help us in recording those thoughts. They can vary. Advanced care planning forms and that process can vary depending upon the state in which we live. And I have some resources at the end where you can get more information about this. So keep in mind that the principles of palliative care remind us to prioritize what matters most. So we want to be always thinking in terms of what matters most to this particular patient at this particular time, and to identify what's interfering with their quality of life at this moment, so that we can ensure that the treatments the patient receives are congruent with their beliefs and preferences and wishes. We want to have what we call shared goals of care. So we prioritize the concerns and we base our interventions on the values of that particular person. Our questions are, what's a good day look like? What worries you about your future? What's most important right now? What keeps you from being able to do that? And again, for most people, it's their relationships. I want to be with my grandchildren or my children. I want to be able to spend time with my pets or my family or involved in my faith tradition. I want to be able to go to church or to go to school or to go to work. Being able to participate in the things that matter most are at most people's top priorities and concerns. Now, if a person has a serious illness, there may be an invitation to participate in something called a clinical trial. And early phase clinical trials are designed to test out the safety of a new treatment. And for many people, that's something that they might be interested in doing. But it's important that, again, a person understand that a clinical trial has the possibility of, again, benefiting future people, but may not benefit that individual. So it's important for folks, again, to have what we would call informed consent. You need to make sure that if you're considering a clinical trial, that you understand and can weigh the benefits and potential burdens. It is compatible with palliative care. And in fact, congruent palliative care with attendance of a clinical trial has the highest quality benefit for the individual. So I wanted to remind us that palliative care and the principles of palliative care are appropriate at every stage of a serious illness, from that moment of diagnosis through whatever treatment interventions a person might choose, even engaging in clinical trials. Now, some of the conversations about a serious illness can be what we might think of as challenging. Being able to really think about these kinds of things in an honest and overt way can be a difficult thing for us to do. It can challenge us again to really look at the um, implications of a treatment and to honestly ask whether or not that treatment could be worse than the illness, and to be able to be thoughtful about really asking specific questions about what the quality of life impact would be. This quote that is on the slide is from a caregiver who was really intentional about being proactive and protective of his loved one. And he was inviting us to think about the importance of knowing to ask these kinds of questions. So some of the questions to think about are, what's the best that we could hope for by trying another treatment? Sometimes we might be thinking that another round of chemotherapy has the potential for cure, when the reality is that extra round of chemotherapy is unlikely to be curative, but more expected or hoped to extend life for a shorter period of time. So we need to better understand so that we can make choices that again are more accurate, and understanding what those side effects might be. And by requesting to have a palliative care team at our side, if we decide to go through with that intervention, can again help to minimize the effect on our quality of life by those side effects. So we want people who are facing serious illness to be able to go through their experience in the very best way possible. Again, to minimize regret and to think about what we might call conscious legacy building. Being able to think about, again, how do we create opportunities so that the person can do what needs to be done to maximize their quality of life at all times. There's something called the dignity therapy model that was developed by Harvey Max Chochinoff. He's a wonderful clinician from Canada who's done a lot of work in this area, and he's created a series of, well, it's an intervention, but has a series of questions as part of that intervention. And I pulled some that I thought, again, are particularly valuable within the context of palliative care or hospice. Questions about your life history. what you'd want your family to know or remember about you, thinking about the roles you played and what you've accomplished, feeling if there's, exploring if there's things that still need to be said to your loved ones, what your hopes and dreams are for them, what you've learned that you want to pass on to others, and what words you would like to offer your family to prepare them for the future. Again, thinking honestly about the possibility that there might be a future time for them when you are not there. And those are the types of questions that, again, can help a person to have the very best quality of life. Again, these are some dignity conserving strategies, helping us to be mindful that we want to make sure that the people that we care for have a chance to do generativity exercises, to be thinking about what they leave behind, that they have an opportunity to look forward to things, to have autonomy and control, to grow in acceptance toward what their experience is, to have resilience, to be able, again, to live in the moment, to maintain some degree of normalcy, to seek spiritual comfort and find solace in their practices. Being able to have a continued sense of self. Too often our treatments have people literally saying, I look in a mirror and don't recognize myself. I'm not sure who I am any longer. So being able to help people to maintain some sense of these kinds of things helps that person to feel, again, the best possible quality of life. So hopefully at this point, I've emphasized and you can see that palliative care is all about being able to contextualize care so that we can ensure that care is culturally congruent and individualized. And if we're going to do that, then we can recognize that the future of quality care is not going to be limited to the hospital, but it's going to be focused on where people actually live and work and play and pray, so that people aren't spending time, again, transporting people to a place and then spending time in a waiting area or a clinic, not able to be doing the things that matter most. So it's an invitation for us to stop and think, what would quality care that's person-centered, family-focused really look like? And how can we provide that? It's an invitation for us, again, to take care outside of the hospital or clinic walls to where people actually live and work and live and do the things that matter most. So to help us in thinking through these future, this identified goal of our quality of care, I highlighted again some resources. Those of you on this webinar know the wonders of triage cancer. But a reminder that there are lots of resources that are out there that can give us more tools, these in particular for advanced care planning. There are resources there as your illness might progress from the National Cancer Institute or the Cancer Information Service. The Administration on Aging has great resources, the Centers for Medicare and Medicaid. There's 5 Wishes, the American Cancer Society, Cancer Care and Cancer Support Community. We have CAPC, the Center to Advance Palliative Care. Livestrong and the National Hospice and Palliative Care Organizations have great resources. The National Coalition for Cancer Survivorship and Family Caregivers Association, the Patient Advocacy Foundation, so many great resources where you can dive deeper into some of the topics that we've just touched on today. And I threw in a bunch of fun movies, and I say that word intentionally, fun. Things like Coco and Up. These are Disney Pixar movies that have been tremendously popular, really well received, but that invite us to think about and reflect on thoughts about end of life and bereavement and what matters most. Again, so many movies that have just regular movies out in the world, things like The Descendants, so many others. And I also pulled some that were more specific to thinking about end of life and thinking about care at end of life that could be used for training purposes or, again, to invite reflection and discussion about choices that we might want for us or our family members if our illness were to progress. There's books we might choose to read. These are things that would be in the lay world. Again, Tuesdays with Maury, Atul Gawande's Being Mortal, Dying Well by Ira Byock. Again, so many wonderful books. More recently, When Breath Becomes Air, one of the most amazing books that I've personally ever read. Again, have a box of tissues handy, but things that remind us to think about these aspects of care for either ourselves or again for those that we might love. Our guiding perspective, for those of you who are providers or clinicians who are listening to this webinar, our perspective needs to be always what's in the best interest of those we serve. If for those of you on the webinar who might be the care partner of someone, again, I think that this guiding perspective is yours as well. You know, thinking in terms of the person that you're providing care for, always being able to hold what's in that person's best interests. If you're the patient, again, being able to express that, letting us know, letting either your family, your healthcare providers know what matters most is so important. We want the care that we provide to be tailored and targeted to your individual needs. And I believe that gives us a few minutes for some questions, any comments that you might have, any thoughts if you're a provider about next steps that you might be interested in taking. I'm happy to discuss anything that might still be of interest to you. Madison, are there any concerns or questions that have been raised?
Yes, thank you so much, Shirley, for that great presentation. And as a reminder, if you have any questions, please type them in the question box to the side of your screen and we will get to as many as you can. But Shirley, we have our first question from Andre. He asks, how do I ask my healthcare team about palliative care if they don't suggest it to me first?
That's a fantastic question, and unfortunately all too common of an experience. Many, again, remember our earlier comments about people, even the providers, again, having myths and misperceptions and thinking that palliative care is too often associated with end-of-life care. And so having that thought that becomes a barrier that says to that person, oh, they're not ready yet, they're not there yet, the provider might not be thinking about palliative care until literally the person's facing end of life. Too often, palliative care and hospice are seen as almost simultaneous terms. They forget that hospice is only a small subpart of the total of palliative care. So again, a really great question and a common concern. A person from the very moment of diagnosis benefits. There's been many wonderful studies that have been done and are documented in the literature that tell us that the best outcomes are when palliative care is offered early in the disease trajectory. So the earlier, the more benefit. Being able to have good pain and symptom relief and have the very best team approach to addressing all of the concerns that a patient and family might have allows that person to do better, be stronger, and be able to get the most benefit from those disease-modifying treatments. So your question is right spot on. How do we ask that if they don't offer it to us as early as we might benefit? So what I recommend is literally making, I think it's a good idea for a person who's going in for a doctor's appointment of any kind to make a list of questions. And that list is probably going to include things about your treatment, you know, maybe some medication changes or some new symptoms that might come up. Whatever concerns you might have, you want to jot those down so that you're prepared when you go in to see your healthcare provider so that you know you can maximize your time with them and make sure that you go home again without regret, saying, oops, I forgot to ask about, you know, my medications or about going back to work or whatever it might be. In that list, you can ask literally, you know, doctor, is there a palliative care service that I could talk to? So that you write that down so that you don't forget. And then literally, as you're going through your list of questions, you can tie palliative care to that. Let's say, for example, you're a person dealing with cancer and there's some discomfort that you might have. So as you're telling the doctor about the pain medications that you're taking and how they're helping some but not 100%, and you're talking about your constipation and the challenges of the opioids that you're dealing with and whatever it might be, that's a perfectly natural and wonderful time to insert, Doctor, I'm wondering if there might be a palliative care specialist that I could talk to about this as well. And any good doctor is going to recognize that as an invitation then to explore that in more depth. Hopefully that becomes code for that doctor to remind him or her that we need to look at the quality of life concerns and to think about a team approach to addressing your care. So again, that's a really fabulous question and a good reminder that we can literally explicitly just ask if there's a palliative care service that you might also see.
Great, thank you, Shirley. That is all the time we have for today. If we weren't able to get to your question, please feel free to reach out to us by email. But before we go, I just wanted to remind you all of the requirements to receive continuing education credits. You must have registered online for today's session. People who are listening in on someone else's computer are not eligible for credit. You also must have attended the entire webinar. No partial credit will be awarded. Anyone watching a recording of this webinar will not be eligible to receive credit. Within 1 week of this webinar, complete an evaluation and post-test. You must receive a passing grade on the post-test to be eligible for contact hours. You will receive an email following this webinar, which will contain the link to the evaluation and post-test. Please note that on the evaluation, it asks for your name and email address. You must include these so that we can certify that you completed the evaluation. That email address is what we'll use to mail you the certificate, and we will be sending out certificates within 4 weeks. For other types of healthcare professionals, we are more than happy to provide a general certificate of attendance. Just make sure to indicate that request on your evaluation. If you have any questions or experience any problems, email us at info@triagecancer.org. Thank you again, Shirley, for the wonderful content, and thank you all for joining us today. We hope that you have found this presentation useful and will continue to stay connected with Triage Cancer.